presentation of Open Med School. I am Dr. Andrews, Professor of Medicine, Consultant. So the topic is beta blockers after myocardial infarction. Effects according to sex in the REBOOT trial. This came in the European Society of Cardiology 2025. What is a REBOOT trial? This is a sex-specific analysis. It's a short form, treatment with beta blockers after myocardial infarction without reduced ejection fraction. So from this the name REBOOT came. So we'll first discuss the summary. The question is, do beta blockers post myocardial infarction in patients without reduced ejection fraction benefit women and men equally? Is there any benefit? If some benefit is there, is there a sex difference is there? Design, it is a subgroup analysis of the REBOOT RCT. 8,438 patients, 1627 women and 6811 men. Follow period was 3.7 years. The results, there is harm in women, hazard ratio 1.45. No effect in men, hazard ratio 0.94. Conclusion, beta blockers post MI in patients with myocardial infarction and preserved ejection fraction, the woman is harmed. The background and aims. The ESC guideline 2023, AHA guideline 2025 recommend beta blockers post myocardial infarction regardless of ejection fraction. The landmark trials are old and in which the woman inclusion was less. The contemporary RCTs reduce AMI show no benefit in patients with the LV ejection fraction more than 40%, that is, in patients with the preserved ejection fraction in the recent trials, and RCTs show that there is not much benefit. Aim of this subgroup analysis was to assess sex-specific effect of beta blockers after myocardial infarction with the preserved ejection fraction. Methods. It's a multicentric trial RCT in Spain and Italy. MI patients with LV ejection fraction more than 40% but no heart failure were included. Randomized discharge with the beta blockers versus no beta blockers. No placebo trial was done. So as mentioned, here shows the number. The woman 1627, far less than that of the men. The primary outcome were death, myocardial infarction, and hospitalization for heart failure. So the results in women, their higher event rate with the beta blockers, 30.4 versus 21 per 1000 patient years, with a hazard ratio 1.45. This is mainly for mortality. In men, hazard ratio was 0.94, there is no significant effect. So what are the limitations of the trial? Only, as mentioned earlier, only 19% were women. Open label design, variable beta blocker dosing, strengths, largest RCT database of women with preserved ejection fraction post MI. The contemporary care with PCI, double antiplatelet drugs and statins were used. Discussion. Women were harmed by beta blockers, especially with those having preserved ejection fraction and ejection fraction more than 50% particularly. Men had no benefit. In moderately reduced ejection fraction also, there is not much effect. Possible mechanism, the pharmacokinetics, pharmacodynamic differences, adverse effects, underuse of other therapies, we don't know. Challenges, the current guidelines recommendations are administration of beta blockers irrespective of the ejection fraction. Clinical implication, maybe in future routine beta blockers in women with preserved ejection fraction post-MI may be avoided. Men, no benefit, but was not harmful. Guidelines may need sex-specific updates in future. Future research, there should be stratified RCTs, dose responses, mechanism studies are required. Take home message: women with myocardial infarction and ejection fraction more than 40%. No benefit but possible harm by giving beta blockers. Men with a post-MI beta blocker with a preserved ejection fraction, no benefit, no harm. So you may have to move towards sex-specific individualized post-MI therapy. Thank you.